Friends, we're going to start the next session in a couple of minutes. That is the most challenging case of the year. It will be a very, very interesting session because it's going to be video based and it's going to be what are the challenges we have faced in the last 1 year, or what the most challenging cases, the most tricky situations, and how we have managed this. And myself and Dr. Kumar, Dr. Kumar Doctor is the chief instructor for this course. I am the co-instructor, and will make sure that it is very interesting and also very interactive as well. And each speaker will be for about 8 minutes, then followed by some discussion as well. At the end of the session, we'll have the discussion.
This is the area of the leucoma, this is the area of the leucoma. The rest of it has got peripheral anterior synechiae. So this is the nasal side, this is the temporal side. It's a dense cataract, and the only area where there is no peripheral anterior synechiae is this, okay? So now the question is what to do and how are we going to handle this case? So this is one tough case that I did this year, and I'll show you another one. So I just held the eye to just analyze as to really what has to be done in this case. So you see a marking, this is peripheral anterior synechiae, this is a slit lamp, which is, you can see the iris is plastered to the back side of the cornea, and this is the center part, and then I got the coaxial light on, and you can see the marking that I've done. So now you have only one area where there is no peripheral anterior synechiae, and that's where my incision will be made, and that's what I'm doing. You can see the anterior synechiae is still this area, peripheral anterior synechiae. So now make sure that your tunnel is little long and little anterior, so that even if there's an iris prolapse happening, will not happen. Again, you can see the 180 on the left side, so I'm now doing a toric marking because obviously the patient had a toric IOL that was necessary. You can see the 180 degree and then the marking of the toric. So now to prevent the rest, now remember one trick here, do not break your peripheral anterior synechiae. If you break it, the iris becomes floppy, and again you are in trouble as far as the surgery goes. So to get better visualization, I put one iris hook in this area so that the iris goes a little back. The rest of it you don't really need to bother about dilatation because it's already that much dilated. And I'm not going to break all these anterior synechiae that you see. Little bit of support on the other side with the hook. You can see I'm again doing a hook and then making it sure that it's further dilated. And I got enough space to do phacoemulsification. So you can see that I've put two hooks, okay, and now going ahead and doing phaco. You can see the behavior of the anterior capsule. It's a little different. When you get those vertical folds, that means the traction on the anterior capsule is less, and in such cases one has to be a little careful. So once your CCC is done, your visualization is just in the center. Remember that. Your visualization is just right in the center. And then do your hydro procedure. Make sure a little bit of rotation is achieved. Go ahead and do your phacoemulsification. So now that's phaco that is on. And once the phaco is done, you have to do irrigation aspiration with a toric lens implantation. After this, I will show you what I did to the peripheral anterior synechiae, whether anything else is possible or not. This is followed by IEA. IEA is completed. Fill in the bag with the viscoelastic. So you can see that I'm filling up the bag with viscoelastic. Two hooks are still in place. You have a nice round rhexis. And don't bother about the adherent glaucoma. Let it be as it is, because you try to do anything there, it's not a great idea. Go ahead and put a toric IOL in the bag. So once the lens is in place, dial it in the direction of the axis. And then I'm going to remove the hooks. So once the toric IOL is placed, you can see that the lens, you can see the 3 dots. Rotate the lens in position and align it with the marking that we had done manually. In this case, I did not get a Virion image. I have an image guided system also, so I decided to do manual placement of the lens. Once this is done, we are going ahead. You can see a nice round rhexis and remove the hook. So the hooks have been removed. And now you can see I'm visco-dissecting the peripheral anterior synechiae. I'm trying to go above it and trying to dissect it and see whether that patient did obviously have glaucoma, that's understood, was on medical line of treatment, well controlled. So here I'm trying to dissect it. I did not do this before doing the cataract surgery, obvious reasons that will make the iris a little floppy. And this is a visco-dissection. So I'm breaking the peripheral anterior synechiae as much as possible, only by visco-dissection, and then moving the iris repositor and again separating whatever necessary adhesions are necessary. So this case where only little area where there was no peripheral anterior synechiae with a toric IOL and then removing the viscoelastic. So it was quite easy, ultimately well managed the whole case and results were very, very good. But sometimes you can land in a situation like this, okay? Or sometimes it can even be like this. But then what? So I'm now going to show you one of the most tough cases we have done. So here we can see that a patient came to me like this, no financial interest. So what does the patient really have? Okay? I call it challenging the challenge. You can see sphincter atrophy. So a case with irregular shallow anterior chamber, small pupil, patient had an angle closure attack of glaucoma, patient has prostate. Oops. Sorry, can anybody go back? Yeah, just same video. Thank you. So patient had an angle closure attack of glaucoma, patient already had a peripheral iridectomy, and patient is on medication for prostate. So you know how the iris is going to behave. So what really happened here? Now, what you really can't see is that there was some amount of subluxation. So I'll show you the video. So patient has PA, it's a hard cataract, and we noted subluxation, and the patient wants to have femtolaser cataract surgery. Okay? So now what? So I'll show you the patient when we examined on slit lamp. So you can see when the patient moves the eye, and you can see the donesis. So you can see a very shallow anterior chamber. There is already a sphincter atrophy, and you can see a PI, and now the patient is moving the eye, and you can see the subluxation. So here what we decided to do, because the pupil is small, went ahead and put in a Mulligan ring, did the registration, so got my incision in the right position. Once the incision is done, I went ahead and put in a Mulligan ring. Once the Mulligan ring is placed, put your viscoelastic near the incision, change the settings for the femto. Okay? So do not fill up the bag, or do not fill up the anterior chamber with, you can see the subluxation with the viscoelastic, otherwise your femto won't work. So this is a femto, you can see the Mulligan ring in position, and you can see a tilt, and that's the subluxation that is there. You can see the position of the iris, very, very close to the cornea, and got approved. So it takes about a second to do your rhexis, followed by phacofragmentation with the laser. So once that is done, we shift the patient back. You can see a nice round rhexis. And don't forget that there is a subluxation. So I'm going ahead and going to do phaco in such cases. And now I need to support the bag. So don't forget that also. So I'm making a side port to support the bag and going ahead and doing phacoemulsification. So you can see that I've done phaco. At one stage, I felt even the bag needed support in this area. So now we have a Mulligan ring. We have hooks holding on to the bag. And that means there was a subluxation. I'm again holding on to the bag. Now, if you use these hooks to support the bag, your incision has to be slightly posterior. That means scleral and not corneal. Followed by IA. Once the IA is done, I go ahead and put in an endocapsular ring. Obviously, you can see the endocapsular ring going in position, and followed by IOL. So endocapsular ring, obviously, it's a subluxated cataract, so you need the endocapsular ring, and then followed by placement of the lens in the bag. So very shallow anterior chamber, irregular rather shallow anterior chamber, subluxation, femtolaser, phacoemulsification, hooks required, endocapsular ring placed, and the Mulligan ring removed, and air bubble placed. You can see the patient's first day post-op, slight SK superiorly, you can see, otherwise the center is reasonably clear. So it is possible to do a tough case like this, all of this under topical anesthesia. This patient was not blocked. Thank you all for your attention.
I think both the cases were really fantastic. Kumar, the first case, the important message is when you have a peripheral anterior synechiae, don't release the synechiae till the end of the surgery, because once you release, as he rightly said, the iris can become floppy, come into the port. The second case, I am a little apprehensive about using a Mellugan ring and then going back and forth, open eye femtocataract. I may be wrong, I may be right, I'm not sure. I just want your opinion, as well as opinion from the audience as well.
Yeah, my thought would be this has been discussed, and I've talked to Professor Chi also about the same thing. Only disadvantage with the Mellugan ring is the incision port is too large. And I'm not taking a suture, but I'm putting Helon 5 at the incision level and sealing it off, and keeping aqueous, rather saline or BSS in the anterior chamber. So that's rule number 1. Now, with the BX there, you can do the same thing through a 1 millimeter port. So if you have a good tunnel, and again, you have the same femto I have, the pressure that rises in the eye is only 12 millimeters of mercury. So you're really not making the pressure 60 millimeters of mercury. So if you have a 1 millimeter side port, rather less than 1, put a B-hex and do the same thing. I think Sri Ganesh has done that and demonstrated that. I think it's extremely safe. The biggest advantage I got was to do a rhexis in a subluxated cataract. Would I prefer of not using the ring and then putting iris hooks, because that will actually tell me the area of subluxation, because here the area of subluxation was unknown. So I presume that it was from about 12 o'clock to about 5 o'clock or about 11 o'clock to 4 o'clock, whatever, because the whole nasal side was subluxated. But I still could manage, even using a little bit of, I think I use, as you saw, I use iris hooks, I didn't use capsular hooks, but I still escaped the issue. Ideal would have been to use capsular hooks. That would have been the best thing to do. But as you start doing subluxated cases, you will love to do the CCC. I've done so many of them on a subluxated case with the femto, and it makes your life much, much, much easy.
Yeah, but I mean, if you can get the incision smaller,
Yes.
and then you can remove the viscoelastic and replace it with BSS, then you don't have to titrate your femto power. So
Then you don't need to even adjust the energy level.
I
That's what the energy you don't
would prefer to put a suture.
Yes,
There
I
is a
agree.
study-
It's very
There's a study
individual.
by Michael Lawless long back, I mean, when they
Yeah.
started with the Lensex. So that they used to use sutures because the docking was more difficult that time, because the docking was rather hard docking then. So nowadays,
Probably
I think
the
that's not an issue.
Lensex, because it produces more vacuum. With the catalyst, it's less. Any questions from the audience on these two topics? Anybody wants to add or?
Suven, you'll speak next. Mohan, yeah. If there is no discussion on this, Dr. Mohan Rajan will show his tough case this year. We have Dr. Gaurav and Dr. Chitra here. Please come on stage.
Good morning, ladies and gentlemen. Let me thank Kumar for this wonderful session. So what I'm going to talk about is something which is a little challenging. I'm going to show you a couple of cases. The first one is, you can see this lens, okay? There's a lot of phacodonosis in this lens. This was an IAS officer, and he had a surgery with us 15 years back. And he was smashed by his wife because he was found glued with his girlfriend. So, and that is what happened to his, lens. He had 6/9 vision. How do you operate this? This one, 6/9 vision, and he had oscillopsia. That was the main problem he had. Oscillopsia, this thing was moving around, and that was the main thing. So what we thought was, being a multi-piece lens, we thought we will glue the same lens. So this is the advantage or the versatility of the glued IOL. You can see I'm making the flaps, then I'm making an infusion in the pars plana. That is a pars plana infusion. Sometimes I use AC maintainer, many times I use pars plana infusion. So what I'm trying to do is I'm trying to disengage that lens from the bag and put it in the anterior chamber. This is very important. The whole ball game is played with the infusion and not with the viscoelastic in a glued IOL. And everything is done with a small incision. You can see here, I'm putting one incision here, going underneath the lens and doing a vitrectomy as well. making sure that I remove the vitreous. It's very important that you remove the vitreous which is there in the pupillary area. And sometimes you can use tricot. In this case, I didn't want to use a tricot because he had a family history of glaucoma as well. So this is you can see here, I am externalizing that haptic. Being a multi-piece, this is an MA60 lens which he implanted 15 years back. I'm externalizing. Externalize, you need to go with the, what you call the epsilon forceps or the MST forceps and catch the tip of the haptic and externalize it. And then we create tunnels, and this is tunnels which we create for the glued IOL. This is a flap underneath the tunnel, and you can see here I'm just doing making sure there's no vitreous in the anterior chamber as well. Pupil is round, and the lens is very stable, and the main ports are, the two ports are sutured. Making sure that air bubble is there in the anterior chamber, pupil is round, there is no vitreous in the anterior chamber as well. And this completes the case as well. You can see the postoperatively 6/5 vision, no oscillopsia, and the lens is not moving a micron. And this is one of the beautiful advantages of glued IOL. Unlike the scleral fixation, which has got still pseudophacodinosis. And scleral fixation would have been so difficult with a small incision in this, because if you do a suture scleral fixation, it's very difficult to put a sutures unless you externalize it. It's so difficult. And glued IOL makes it a very, very interesting feature. This is a 1 month post-op, 3 month post-op, and again the patient is doing well. There's another patient you can see here, again a dislocated IOL because of trauma. Again a multi-piece lens implanted long time back. This patient was done, the surgery was done elsewhere, the primary surgery. And what I'm trying to do is to free the lens from the vitreous, free the lens from the capsular connections as well. So that is very important. All with the side port incisions, with the smaller gauge instruments, you can see I'm using a 26 gauge needle to literally strip off all the capsule. And this is again very important. Strip off all the capsule and the cortex from the IOL. And that is very, very important, because when you do the glued IOL, we don't want anything to come into the sclerotomy port. And again, making sure that vitrectomy is done, and because as you all know that this can happen, and because of trauma there is also a little bit iris damage as well in this patient. Again, I'm using the epsilon forceps, the glued IOL forceps, which goes through the side port and externalizing haptic, and making sure that the lens is there. And once you externalize the haptic, and you can just put it in the tunnel there. And this again, I'm using, you can see here how I'm doing the externalizing the haptic. That is very, very important for you to understand. Already the existing PI is there. I mean, you're removing the vitreous which is there in the anterior chamber, and always remove the vitreous from the sclerotomy port as well. You can do a dry vitrectomy there. And when you put the glue, that is very important. Make sure that the entire area is very dry. Leave it for about 30 to 40 seconds. And because if you have the saline in that area, the glue will not act. So you put the thrombin glue first and the fibrin glue. You can use either really seal the other one, Baxter as well. And there is a funnel, and the patient's vision also improved. There's another patient you can see here. This is a subluxated cataract. This is a one-eyed, my anatomy professor. He had a subluxated cataract, hard cataract. The other eye was ambulopic. And you can see here, this is a subluxation you can see in this quadrant. And this is a hard cataract, about grade 4 cataract, brown cataract. So what I did was, initially, I did a Rexis, and making sure that the trypan blue does not go, because if you leave the trypan for a long time, it can go through the zonal dialysis into the anterior vitreous, and instead of a red glow, sometimes you can get a blue glow as well. So that is a big problem. So once you put the CTR, you stabilize the bag. Ideally, the capsular hooks should have been used, but I always use iris hooks for the capsular bag. It doesn't, I have not encountered any problem except in this case because of the mistake I did. So this, as I told you, this is a hard cataract. I'm using the Stellaris machine. Normally for the hard cataracts, I use the Venturi system, which is very important. You can see here, the capsular hooks are holding it. This capsular hook, notice this capsular hook, this iris hook, which is holding. I should have actually removed it during the cortical aspiration. I always use coaxial irrigation aspiration. And when you have a CTR in place, the most important thing is the trick is to go circumferentially instead of coming radially. And this makes a lot of difference as well. You can see here, this capsular, this iris hooks has given way. And because I was holding that bag for too long a time and too much of traction and went back and produced a posterior capsule rupture as well. You can see the PCR here as well. But I thought I'll be able to put a MA60 lens, a multi-piece lens, and capture that optic into the capsular bag. So that is one of the important things. But what is more important for you to understand is that the vitreous is still there. So you put the tricot there, then I always do a past planar vitrectomy. I put a trocar and cannula and can see here removing the vitreous from the anterior chamber from behind makes more sense and more scientific as well. And you can have with very less traction on the vitreous, you can actually remove the entire vitreous. So this is a past planar vitrectomy, which you can use a trocar and cannula, or you can just straight away use a sclerotomy. Only thing is you have to make sure the anterior chamber is tight and always put a suture there before you put a trocar and cannula. Sometimes you can have if the anterior chamber is not very tight, which is hypotony, you can have a buckling there. So the patient had a traumatic mydriasis. I thought I'll do a SFT, but I was not able to do that. And this is the end of the case. You can see here the lens is fairly in position. Traumatic mydriasis is there, and all these patients. This patient also did very well. It's almost 1.5 years follow-up now with a 6/9 vision. So I think I have run. The time is over, no?
So one more.
Oh, this Bullgoar injury. I just wanted to show you. This Bullgoar injury was very common about a year back, 1.5 years back. We had Jallikattu problem in Tamil Nadu, in Chennai, and this was a problem where a young fellow, 19-year-old male, Bullgoar injury. I expected a posterior capsule rupture. So I should have actually done a bimanual, but I always do a coaxial irrigation, the coaxial phacoemulsification, but I anticipated a posterior capsule rupture in this patient, which happened. You can see here, as I was removing the cortex, this is a young fellow, not much of a nucleus, is more of a very soft lens material. So I did a bimanual. Once you notice the PCR, then you always go bimanual, never use the main port. So I put a lot of viscoat there. The viscoat is actually a savior for you. And then I did a anterior vitrectomy. Always remove the vitreous which is there in the anterior chamber and then remove the cortex. This is the take-home message. Remove the vitreous which is there in the pupillary area. You can use a 23 gauge or 25 gauge or 20 gauge, whatever is available. Then I did a bimanual IA and removed the cortex as well, and put a MA60 lens in the sulcus and captured it in the bag. And this makes a huge difference, because if you capture the lens in the bag, then what happens is the long-term centration and stability of the lens. You can see here I'm putting viscoat there, stabilizing the anterior chamber, and if there is any vitreous, I'm just removing the vitreous, also the remnants there, and also the you can use the same suction on the vitreous on the cutter as well, and you can go ahead and again every time you come out of the eye, put in viscoat. The viscoat is actually say I don't have any financial interest, but it's really a fantastic game changer for you. And you can see here I'm putting an MA60 lens. Never use single piece lenses in this patient. Always use multi-piece lenses, and putting a lens in the bag. So many times in the sulcus. Many times you leave it in the sulcus. But what happens is the long-term decentration occurs. The stability of the lens is not good. So what I'm trying to do is put the lens in the sulcus, and then with the Kuglen hook or the second instrument, the rod, I am trying to capture that lens, and you can see that post-operatively 2 months, how the captured lens is there, stability of the lens, 4 months, 1 year, with the vision of about 6/6 in this patient. Thank you very much for the wonderful opportunity and the patient attention.
Thank you, Mohan. That was excellent. But we'll have some discussion on this. The case where he showed, he put an endocapsular ring before doing phacoemulsification, okay? And he had some cortical strands which were actually entrapped in the endocapsular ring, and so he had to actually pull it. And when he was doing IA, I don't know how many of you noticed that the endocapsular ring was coming with it. So the trick here is, when you want to put an endocapsular ring before doing phaco, very, very easy. What you have to do is put a heavy viscoelastic, go near the CCC margin, and then start pushing in viscoelastic so that the cortex actually goes down, and you have created a space between the anterior capsule and the cortex. But you have to do this till the fornix of the bag. So keep putting in viscoelastic all around, okay? And that will create the space. Then put the endocapsular ring, your cortex will not get entrapped. Believe me, try this, it works beautifully. Another thing he showed was using iris hooks to hold on to the bag, and then IA was used, which obviously the bottle height was high, must have increased the pressure, and then the capsule gave way and it didn't hold on. So again, best thing to do, use Madhuka, I have no financial interest, capsular hooks. They are not expensive, they are only $500 or 600 rupees, and that will work beautifully and not cause that amount of pull. Another one thought I thought was if that moment he had released them a little bit, you know, technically the iris hooks, when you keep on the capsular bag, it actually tenses up the bag and pulls the bag instead of supporting the fornix. So if you have a subluxation, we need the support inside and not a pull on the edge of the rexis. So this is my thought, that if he had released it, then that would not have torn and would not have happened.
There's a mic behind you.
Sorry. I fully agree with you, Kumar. As I told you in that video, iris hooks can be used for the capsular bag. The problem is, don't keep it for too long and don't keep it for too much of traction. These are two mistakes I did in that case. So once your job is over, once the nucleus is out, you can release 1 or 2 iris hooks from the capsular bag. That will keep because you don't require that anymore. Because already you have an endocapsular ring and you have removed the nucleus.
Mohan,
and you remove the cortex as well to such extent. Yeah.
Though you're the Talavar, I will differ with you slightly over here. Now, the thing is, iris hooks and capsular hooks. We are planning the case. We will not use a CTR in every case. Now the standard of care is that we use bag stabilizing temporary devices, and then we plan what kind of permanent bag secure measure we want, whether we want to use a Sioni, we want to use a segment. So if we are going to plan in that way, then we need to be more organized. So if you're going to use capsular hooks, the support is at the fornix. With iris hooks, the support is at the capsular margin, capsular rexis margin. So that's the wrong area, that's threatened. Okay. And if you did not have a CTR, how would you release that capsular hook, that iris hook? You couldn't do your cortical cleanup because you did not have counter traction to support when you're pulling the cortex. Yeah. So that CTR becomes a prerequisite over there. So it's always recommended.
What I recommend is just remove one of them.
So,
not all of them.
No, when you remove
one of them, then the traction on the bag becomes less. Overall, you don't want the 360-degree traction on the bag. That's what opens up the capsule.
What I'm saying is, if you have 4 iris hooks anchoring the bag, you remove one, and you want to remove the cortex from there. You have no counter traction in that clock hour, that radial, you got no counter traction. So you are going to cause more zonular dialysis over there as you are doing the cortical cleanup. So you need counter traction over there. So there is no alternative to capsular hooks.
I fully agree with you. But, we have used the iris hooks for so long.
Yeah, because they're more easily available, but I think it should be part of our inventory.
The only thing is, you need to use it very judiciously for this.
Yes. Now invite Dr. Chitra Ramamurthy. She has to run out to go for voting in the family. Yes, Chitra, start please.
A very good morning to you, to all of you, and my very special thanks to Dr. Kumar for including me in his very prestigious course. This was a case of a total cataract, and CF was on the femto platform, and the incision on the rexis by the laser had the flocculent material coming out. So I'm not sure whether I have got the entire rexis, but I have used a trifine blue dye, which I normally would not use, but as it goes on, it appears as if the rexis is intact, but I need to be very careful because there could be areas where the tissue bridges may not have cut it, and there could be those tags or tears, but finally the surgery goes on well. But the learning curve in a hypermature cataract is to create a deeper offset in the anterior capsule. So this was a second case. I normally just bunch up a free-floating rexis, but somehow in this case, I need to use my capsule, rexis needle to get it. And that was a very soft cataract. It was softened and segmented, and it literally in a flip mode, it all came off. And with absolute ease, I'm removing the cortex. I just thought I would inflate the bag at this point of time. And lo, behold, the whole capsule comes forward as if it's an intraoperative hard eye. And then I realized why. It was because it was a lax capsule and that area of dialysis, and hence the capsule whole bag had come forward. So at this point of time, my furnace has got caught, so I just release it, and then now is the time I need to inflate the bag and go in with the CTR through the side port and insert it into the capsule furnaces. The removal of the cortex is a bit of a challenge because it gets ensnared by the CTR, but it's mandatory. You remove all the cortex and then position the lens, and I got myself bailed out of this situation. You could see it was a very dense fibrosis of a traumatic cataract, so I expand the area of the rexus so that it's well beyond the presence of the fibrous ring. The patient was a young guy, and the cataract looked quite hard, though traumatic cataracts are largely soft cataracts. I have made the arcuates also to correct the astigmatism. So before you open up the eye, you need to open up the arcuate incisions. Normally I would not stain, but this was again a situation where I needed to know whether rexus was cut because of the fibrous ring, and there could be tissue bridges which could not have been cut by the femto disruption. But thankfully, as you can see, nearly 3/4 of the circumference has been cut. So I thought this dense area where the fibrosis is very intense, I try whether I could manually exert some force, but I realized that I could end up creating a dialysis at this point of time. And however, the best of the technology you may be seated on, you may have to be realistic. At this point of time, I go in with the scissors, and along circumferentially in that particular area, I make a nick, ensure that I have cut the capsule margin at this point of time. The cataract looked quite hard, so I just gently do a hydrodissection at this point of time, and I ensure that the rotation of the nucleus is quite complete as is necessary. But as I try, you can see it is quite actually just a disc of a disc, which is not even a hard cataract. You just go on to the flip mode, and in no time I've gobbled up the thing, because as it is, it has been softened and fragmented by the femtocataract platform. I try to see whether I could get some of these fibrous adhesions, but I realize I'm actually caught in a different mess. The whole posterior capsule gets caught in the IA, and in the aspiration probe, I go in with the infusion, try to separate it. And then I think it just did not make sense to have such a friable, nearly dehiscent capsule. So I go in and do an iatrogenic vitrectomy at this point of time, because I know it's hardly going to be a scaffold to place the IOL. So I inject a bit of triamcinolone to ensure that I've done a thorough and a good vitrectomy, that there are no vitreous strands which have got neglected. There are many other simpler ways by which you could detect whether the vitreous has been removed, when you can just use your my Meroseal at the incision side, and then I inflate the area above the rexus and then position a 3-piece lens and do an optic capture, and it's well centered. This was the next situation, a significant subluxation just held in some areas with the zonular fibers. So I decenter my rexus on the femtocataract platform and ensure, because once it is centered to the scleral wall, if necessary, the little decentration at this point of time is mandatory. Again, the segmentation and the softening has been done. And I'm here again, I do not just bunch up the rexus, so I use my capsular rexus needle and just create the rexus, and it's a very soft cataract, it just comes up. But it's very important at all times, the AC should not shallow to increase the area of dialysis, and I come to strip the area where the cortex is being removed in the most gentle fashion, and then go in with a CTR and position it such that the long arm of the CTR comes to overlie the area of the maximum rexus. This was a traumatic cataract. I did not expect a progression of the zonular dehiscence to increase. So I then go in and position the IOL such that the haptic further stretches. This was a very severe dehiscence. Again, on the femtocataract platform, I've created the rexus because it ensures that I get the right size rexus, which could be a great challenge when your cataract is subluxated and the capsule is lax. Again, I place the capsule hook such that it keeps the capsular bag taut. Removal of the cortex has to be done gently, because if you pull on the capsular fornix, the whole bag would collapse. And then I position the CTR in such a fashion that it supports the bag. And now I go in and create a small triangular flap. There are different ways you could use a Hoffman pocket, but you need to ensure that this kind of subluxation, you need to attach it to the scleral wall. So I do the usual railroading technique. I'm sorry, I pass the suture and then pass the other end of the suture through the eyelet of the Ahmed segment and then push in the Ahmed segment, and this is where I'm going to have a challenge. So I've managed to push it in, but it actually should just float back to occupy its space in the capsular fornix, but it keeps coming back to the incision site. Then I realized probably I've passed the suture through the layers of the corneal lamellae at this point. So I try to open it open it up, and then I realize I've actually cut the suture of the thing. Then I bring out the Ahmed segment, and by the time it has hit the capsule, I have a PCR. So I realize that I have to call the end of the game. I move the CTR, go back in and do a gentle anterior vitrectomy. I need to ensure that all points of time that the CTR is removed. Then I inject pilocarpine and then position a iris clip lens and clip it to the retro portion of the iris, and I bail myself out of this case. This was again another case where the ICL was there, the patient had a cataract, so I had to do certain steps. I had to increase the offset because there's an optical device in the eye, so the anterior capsular offset is increased, the posterior capsular offset is increased because there's going to be a lot of cavitation bubbles which cannot egress because the ICL is sitting in the eye. I've even decreased the vertical spots so that fewer cavitation bubbles are created, and then I just nudge the ICL out of the bag with a hand-over-hand technique. You can see there's a cut on the ICL. So in spite of my increasing the offsets, a cut had occurred. I was a little unsure whether the rexus has been cut in toto, but thankfully it was. But again, this was a very soft cataract, so I'm able to go on to the flip mode and just remove the entire cataract, remove the cortex gently, and then position the lens. So essentially, each of these cases were a problematic case in itself, but each of these small trips and clues helped me get myself bailed out of these challenging moments. Thank you.
I think really fantastic videos, Chitra. I just want to ask you a couple of questions. One is, the traumatic cataract you showed. There was a huge
Area of
dialysis, and you just
Yeah.
put a CTR.
Yeah.
I thought technically you should have fixed that, the CTR, like a Sioni into the sclera.
Yeah, it's just a stroke of chance. One is, we believe that the zonular dehiscence is progressive in particular diseases, and traumatic cataract, it's a stationary event. At that point of time, placing the CTR and also ensuring that the haptic of the IOL stretches the bag and the IOL looked centered, and the incident, the patient has been coming for the last 2 years. This is a 2-year-old video, and he's been doing well. But I cannot refute his argument, and if that point of time I'd gone ahead and done a scleral fixation, definitely it justifies it more. But again, there are many of these cases which do well if the zonular dehiscence does not progress, and which should not. If you have not adequately stretched the bag, then yes, there could be asymmetric bag contracture, and you'd be in trouble.
What is the lens of your choice? You put a multi-piece lens or a single-piece lens?
Actually,
Because
no, this was a single-piece lens,
yeah, I
and
know, but
ideally I should have placed a 3-piece lens.
3-piece,
Yes.
that's what.
Yeah.
A multi-piece lens, a 3-piece
Yes.
lens is what I'm trying to mean. Multi-piece lens would have given better stability.
Better stretch, 100%.
Better stability to the back. Otherwise, your videos are really fantastic. Any questions from the audience or any inputs? And the ICL with the LRCS is really fantastic. And is there anything different you will do for this when you do the femto with the ICL in place?
No, essentially, to those of you who don't do a femto cataract, you have a 300 micron offset for the anterior capsule and a 500 offset for the posterior capsule, so that the cut occurs. But because the ICL is occupying space in the anterior chamber, it makes sense that if you just have the 300 micron offset, you would only cut the ICL. You may not get the full cut of the anterior capsule, which is sitting below the ICL. So if you increase the offset, it's a further guarantee that there is a greater chance that the rexus of the anterior capsule would be surely cut. Again, the other challenge is there's an ICL sitting in the bag. So all the cavitation bubbles which are created by the femto disruption need to egress out. There could be a capsule blowout of the posterior capsule. So instead of the 500 micron offset, if you can increase the offset, you create more space behind the nucleus and the capsular bag for the cavitation bubbles to egress. The third step which you could do is, you do not want so much cavitation bubbles to form. This is a soft cataract which I was dealing with. So I increase the vertical spot spacing. You could play around with parameters. So when I increase the spot spacing, the amount of cavitation bubbles formed is less. So these were 3 efforts which were made to ensure that the capsulorhexis gets cut and the surgery goes on to completion.
Thank you very much, Chitra.
Yeah.
And we
Just
go on to the
one
next
question, please.
speaker.
Yeah,
Next
just
speaker is
one-
Dr. Suven,
Yeah,
but
just
Chaji,
one-
who doesn't require any introduction.
Yes, you asked
In
the
your
question.
Yeah, sorry.
in your practice, how many posterior claw lenses you are putting in a year in comparison to the sutured glued IOL?
No, sutured glued IOLs.
Sutured
yes,
or unsutured?
Yeah. If a retina surgeon has started off his case from the first go, a planned scleral fixation, then they would do a glued IOL, probably. But all of us anterior segment surgeons, when we are caught up in a situation, in every single case, I think all of us are doing iris clip lenses because it has to be done, but it's done so well and so fast. And if you do a good job of it, I mean, ensure that you've done a good vitrectomy, remove the cortex, taken care, there's no some smoldering inflammation. You do 100% well in all these cases. We ensure we do a PI also at the same setting.
Okay, it means that the practice is dominated by the iris claw lenses.
Yes,
yeah,
yes.
okay.
Yeah.
Thank you, ma'am.
Thank you.
Mohan, can I ask you a question?
Yeah,
I have a case just like the first 2 cases you showed.
yeah.
That a multi-piece lens in a bag and the bag is partially on its subluxative.
Yeah,
So when you are pulling the lens out and placing it on the iris,
yes.
I'm afraid do you cause some traction on the vitreous and there's possibility of causing retinal holes.
Yeah.
So do we have to take that risk in such cases?
No, that's why you have to make sure you bring the lens into the anterior chamber. You have to make sure that you remove all the vitreous from the anterior chamber, from the pupillary area as well. Post-operatively, you need to dilate these patients regularly. Look at the periphery for these patients. Yeah, because you are disturbing the vitreous base in these patients. So
first you do some
whether it's iris
vitrectomy.
claw lens or a glued IOL, iris claw is what Chitra is using. I do more of glued IOLs because especially when you have a multi-piece lens already there, and I don't want to exteriorize, put a large incision, explant that lens. So the simple, better way and better stability is to put a glued IOL. Only thing is you need to make sure that there is not too much traction. Certain amount of traction will be there. Make sure that the vitreous is removed. End of surgery you also put tricot in the anterior chamber. Make sure the vitreous is not there in the anterior chamber as well.
In your videos, you didn't show you the anti-vitrectomy. Was it because of shortage of time? You showed only the vitrectomy in the anterior chamber.
No, I went, in the first case, I went underneath the lens and did an anti-vitrectomy.
Okay.
If you notice very carefully. Yeah, one more question and then we go on.
Can
Next.
I just make one comment,
Yeah.
please? See, all of you have shown a case which is either a post-traumatic subluxation. I think it's very important to emphasize the need for a preoperative UBM, if possible, because I think instead of figuring out on the table whether you've got 3 or 4 or 2 clock hours of subluxation, if you actually define it properly preoperatively beyond what you can see clinically, planning of the surgery, whether you want to then put in a CTR or a hook or you want to suture it to the sclera makes a lot of sense.
Absolutely.
No,
Fully agree with you.
I agree with you that yes, it will help, but it won't be a definitive, it won't give you a definitive path because during the surgery, your clock hours are going to increase.
Yeah.
So the idea is to keep your options open throughout and go with temporary capsular bag support initially, which was capsular hooks, and then you plan your permanent. A UBM is definitely going to be invaluable, there's no doubt about it, but it will not give you a permanent plan.
No.
Agreed, but if you have to start with the 5
Absolutely.
clock hours
I agree with you,
subluxation-
Suvira.
Yeah.
But what is important is, in all these cases, have a plan A, plan B, and plan C.
Absolutely, I agree.
Absolutely, absolutely.
This is what I think the take-home message I want to give. Have a plan A, plan B, plan C before you start the case. You do UBM, you do whatever you want. But on the table, it's going to change. The whole ball game is going to change.
True.
And that is what you have to anticipate. You have to anticipate the worst and probably be prepared for that. And that what makes a huge difference. Over to Suven, please.
Thank you, Mohan, and good morning, everybody, and thank you, Kumar, for inviting me to this very interesting session. And now, where's my first slide, please? No problem. We got all the time. Kumar has said we got lots of time, so we can have plenty of discussion. Mohan, Kumar has said we got a lot of time. Okay, so now let's start this with. I just kept this slide like this. So I would like your imagination to go as crazy as you want. Where all could a CTR get stuck? I'll take some votes and some thoughts from the audience. Mohan, where all can your CTR get stuck?
In the sulcus.
Okay. Gaurav?
Capsular hook.
Yeah.
Capsular. Ajay? Angle. Amar sir,
Angle.
where can the CTR get stuck? My CTR got stuck. I just wanted to imagine, think where could it get stuck?
Wherever it gets stuck, he'll glue it.
That I can trust, Dr. Amar. In the bag, okay, great. So, yes? Cornea, okay, great. So, since I'm still collecting votes,
Yeah.
means that we've not reached where I want
it
you
can
to.
go into the vitreous and get stuck in the ciliary
Retina,
body
is
area.
it?
Retina.
I'm still trying to get that bad, but I'm
Yeah.
not there yet.
We had a
Okay,
patient.
let's get on with the business.
And removing the CTR from the vitreous cavity is the most difficult thing I have seen.
Yeah, I know from the vitreous, but I mean retina, choroid sclera would be real tough. Right. So, watch this case very closely. Watch this over here. That's when I wrote this. Did you see that over here? There is a zonular dialysis over here. Okay. So, this is a harmless case to start with. So now I'm injecting viscoelastic and reforming that bag over there, taking my time to now be more careful, and as I remove that cortical matter from there, you can see that zonular dialysis over there. So I'm being very careful so I don't add insult to injury. And well, we got rid of the cortical matter easily. It's probably a few clock hours, 2-3 clock hours. So we're going ahead with the CTR. There are various ways of putting in the CTR. I prefer to do through the side port, and at this stage I would probably use a Sinski and various things. But this day I suddenly thought I would use my 23 gauge forceps to put the CTR in. And well, yes, there are good days and bad days. So the CTR, I went well past the capsular excess margin, and or nearly up to the capsular excess margin, and I thought, well, no, it's not in the bag. So it's gone into the trailing eyelet has gone into the sulcus. Okay, no big deal. We always have it, and that's not my zonal area, so I'm not really worried. Now look at this. Can you just pause that? I don't know if you can figure out. I am not holding it with the jaws. It's beyond the jaws that I'm holding it. I should have been holding it at the tip of the jaws. Instead, I'm holding it over here. And that's where the problem is. Now, I've got a capsular excess forceps on the other hand, handshake technique. Well, it won't come off. What do? Ajay. It doesn't come off. It's retracted into the stalk, into the tube, and it's got jammed. So the jaws won't let go that CTR. Mohan, I give you a call from the theater. Talevare,
Yeah.
kaapatenge.
You have to disengage that CTR.
My CTR is jammed in the jaws of the 23 gauge forceps.
Okay.
Yep.
What
Yeah.
you can do is,
Mic's on for her. The flow mic on over there, please.
Mic is on now.
You can use something like an end gripping force.
Hello.
Yeah,
Hello.
one idea at a time.
Yeah.
Yeah, go ahead.
Hello.
Yeah, we can hear you.
Yeah, what you can do is you can hold it below where it is stuck with the other forceps and then cut it with the scissor.
No, cutting the CTR.
Yeah,
Yeah, cutting the CTR is my last option, because then I'll remove
Yeah.
that CTR. I want that CTR intact with that eyelet and to go in.
I will
I want to
tell
still use that CTR.
I will tell you how to do it.
Hello, Suben?
Yeah.
Yeah.
Can you just go through the main incision, hold the CTR with this and remove it again?
I
Can you do
can't.
that?
How? See, I have to. This is not in the same axis. Also, this is on the.
I will tell you. I'll
it's
tell you.
against the CT.
Yeah, I will give you an idea. Just put viscoat there, okay? Make sure that the chamber
I
is
have
very.
two hands.
Yeah, put viscoat.
I have two hands, two forceps. Okay, one forceps is stuck
Yeah,
over there.
make sure that the this thing is stable. The anterior chamber is stable. Put another right side port there. Use something like an end gripping forceps. You have a bimanual way of removing that. That is, you ask your assistant to hold that CTR from the outside, and you go from this side. You hold the CTR from this side with this forceps, and use something like end gripping forceps and disengage that.
Udamatana, sir.
Suven, how?
Not
have you-
leave. It's
have you-
just got stuck.
So
The
when-
jaws, see what
the jaw-
happened is, let me just explain. See, the jaws are like this. It's the stalk beyond the jaw with which I held it. So that's gone into the tube and it's got jammed. Okay, so now it's in a kind of position where you can't go ahead. I can't push it ahead. It won't release. It won't come out. It won't go in any further. So it's the wrong part of the forceps I used to hold. Because I didn't have very clear visibility at the closer to the angle. Yeah, you were saying
worst
something.
case scenario, if you try to disengage it with some instrument, it comes out. If it doesn't come out, I would just quite gently withdraw the forceps and the CTR will come out with it and you just kind
That's
of
right.
explant it.
How will I? See, it's my left hand. I should go
Is
back.
it the left forceps?
Yes,
which is,
it's the left forceps where it's got stuck.
Oh.
It's the left forceps which got stuck. So I'm
Only, not the one, not the
I
right.
am not. Yeah, let me just go back a little bit and you will.
Suvin, can you,
Can you go back on the video?
Yeah, there you are.
Yeah.
So the right forceps came in just to askew. That's my left forceps and I'm jammed over there.
so can you, Suvin, try with another instrument
Who's that?
underneath
Yeah,
the
Prashant.
forceps and try to, make another opening at around 90 degrees to the where it is stuck. Take an instrument because now your CTR is going like this inside your holding forceps. In between the cleavage, just stabilize it and just try to separate this in right and left hand movement. Probably this will come out.
PMMS CTR, it's going to break.
It is probably the only way you can do is slowly.
Do it
just take
bimanually, that's what I said.
Yeah,
Because if you have bimanual,
I tried a
bimanual, then you have
tried
better
a few
stability.
excursions with my forceps and really wasn't getting any mileage and and actually it's a tricky situation. You really don't have so much of time to think and go back and forth. So below what? See, it's caught between the two jaws. It's,
Suven,
yeah.
Passing an iris spatula from below and then trying to push it that side.
See,
Suven,
there's hardly any space, but the jaw it's jammed over there.
Now, iris spatula between the instrument and between the
Which
CTR,
instrument?
between your forceps
Forceps
and the CTR ring. Pass a iris spatula from
That
the
is
main
not the
wound
forceps.
and
Let's
try.
talk of the jaw of the forceps. We have the jaw of the forceps, the upper jaw, the CTR, and the lower jaw. And it's not even the jaw, it's the neck of the jaw. I don't have room over there to pass an iris spatula. I don't have room over there to blow air also or inject some BSS also in between.
Suven,
Yeah, let's.
take
Yeah.
iris hook or a Sinski hook,
Yeah.
put it into the hole and slowly you pull it out. And this you try to keep on pressing, releasing, it will release automatically.
If I press and release, the CTR will break also.
No,
So
no.
PMMS CTR.
No,
Seven, can
it
you
is
go-
already
go ahead
got
with the
stuck.
video?
Go
You
ahead,
are
I think.
pulling it out.
Timing.
Okay.
Through the hole, you are pulling it out.
Okay.
Yeah, let's
Right.
go to
So
the
we have
video.
had enough of discussion and
You put
food
the
for
reverse
thought, let's
order.
say.
You put in a, you advance your forceps in front,
It
and
doesn't-
then keep your CTR backwards, and then once it
No,
has
I-
done the same process.
how do I hold the CTR otherwise?
Advance, you have to
I advance the
Before-
forceps, and how do I pull the
More than-
CTR backwards?
backward push.
With what?
Okay, let us see how you did it. Yeah,
Yeah.
Suvan. Suvan. let us-
Okay,
Yeah, let
good,
us
good,
see.
good. So then I was not the only sorry guy over there. Okay, so I got you thinking also. So, well, I had a capsular access forceps and held it, and I'm going to try to release that jam. Watch it very closely. Ah, see that? It's getting released. Wonderful. What got released? The eyelet has come out. So now I have a jammed CTR, broken, sharp edge, with eyelet in one hand. I'm sorry. Can we go back, please?
Can you just make it fast, Suvan, because running short of time.
Okay, fine. So, yeah, so now I've got a jammed CTR, the eyelet in the other hand, and the CTR stuck over there. Now what? It still doesn't come off. I'm praying hard. Well, so I try to hold it. At last, yes. Okay, now what? I leave it in the bag or take it out? Mohan.
We can leave it in the bag, nothing to do.
Well, that's what, I didn't want any more heroics that day, so I said, okay, leave it in the bag. If it goes out of the bag, we'll deal with it in a second sitting. We'll call up Mohan and find out what we can do, and then we will decide. But then again, it had to be my luck that day. So I left it there, and again it didn't go into the bag, into anterior chamber. So anyway, we go ahead and put it, and again, so this time I was not using that. So this time I take it all the way so that it's least traumatic and at the fornix, and it does not damage the fornix. So safe landing over there. And for now I have a round capsular rhexis, so I know that it's in the in the fornix very well. And we put in the lens, and well, yes, and we have post-op pictures on day 7. Being extra gentle, so I shouldn't move that CTR too much so that it doesn't perforate. And this is post-op day 7. This patient has been on follow-up for quite some time. Ideally, I should have done a UBM, but never felt the necessity because the lens is very well centered. This is not any haptic or something. This is just a reflection of light. So this patient has been doing so well. So the idea was, if you can probably leave a broken CTR in the bag. Yes. Yes, the take-home message is probably my
The take-home message is, all these crazy things happen only in Kolkata and West Bengal. Yeah. Yeah.
There are 2. So yeah, this is a take-home message. That was, I inspected that forceps later very closely, and the tube, it's stainless steel forceps, so the tube had kind of cracked over there, so that was one of the reasons why it got jammed. So probably it's a better idea to use titanium forceps. Thank you very much for your kind attention.
Beautiful, very nice, Suvan. We have a lot of discussion go on to Gaurav Luthra. Gaurav Luthra again doesn't require any introduction. He's king of Dehradun, Uttarakhand, and he's doing really fantastic work in the anterior segment. And he'll be talking to us on some tough cases. That's really very interesting video, and you also had the floor on very good discussion, lot of thinking.
Yeah, thank you.
Thanks,
Mohan.
Dr. Mohan, and nice discussion, Suvin. So, a very good afternoon, good morning, everyone. Is it already? Yes, almost 11:30. So, I had this patient, Kumar wanted me to show a few subluxated cataracts, and this patient had a subluxated cataract with some synechiae superiorly, and we had seen him on the slit lamp that there was a subluxation in this area, but it did not look very bad, and I did not do the UBM as Suvira Jain was suggesting. Anyway, so we went in with this surgery, and I was going to stain this, and on the slit lamp we had not seen anything extraordinarily wrong, and I'll tell you why I'm saying that, because the moment we put in trypan blue, what happens is that I realized that trypan blue is not going into this area. So what had happened is that the patient had been examined only in the sitting position, but the moment the patient goes down into the supine position, and this patient is under blocks, peribulbar block, so we noticed that the dye doesn't go there because there was vitreous which was presenting from that area of subluxation, which probably came in much more after the patient was in the supine position and with some of the hypotony associated. So anyway, if you don't have triamcinolone, you can stain it with trypan blue. I'm not recommending it, but it can be done. And here you can see that we are now, it is absolutely essential to remove every bead of vitreous that you can find, otherwise you will not be able to proceed with the surgery. A meticulous vitrectomy can be repeated even during the case. Sometimes some more vitreous will come. We free the synechias, and I do realize at this point that the subluxation here is quite significant, and it's a bit of a small pupil, so I'll have to tackle both things. So we start with the rhexis, and it's a subluxated cataract, so I have to be very gentle with the rhexis, which eventually does happen, and I'm able to complete the rhexis. Now I'm going with the capsular hooks, as Suven was pointing out repeatedly. Now these are MST hooks, and I have no financial interest, and they are wonderful hooks, yet I wanted to show you this video as to where you can go wrong with these hooks, and sometimes it's challenging to actually use this hook. Please see here. I'm trying to latch on to the rexus edge, but my repeated attempts are failing. In fact, even now I've managed to only catch onto the iris here, and I'm not actually latching onto the rexus. So to get a better hold onto the rexus and have better visualization, I've put 2 iris hooks to dilate this pupil, and now I think I'm going to go back and try and put this capsule, and I'm trying to identify the rexus edge so that I can lift it up a little bit with my manipulator and try to put this capsular hook in place, which still does not happen. And the reason it's not happening is because the subluxation was so much that the capsular hook could not reach the area of the subluxation. So I decide to change my clocker where the subluxation is less. So at this point the subluxation is less, and I'm immediately able to catch on to the capsular rexus edge, and once I do that and the lens comes up, now I'm able to do this one as well. So sometimes if you try to go on and latch on to the area of maximum subluxation, you may not be able to catch on to the rexus. So you can then start from the area where the subluxation is a little less, and then once the lens is lifted up, you can then go into the other clocker meridian, and then you have a nice thing. So this is a small pupil. We are using 2 capsular hooks which are also helping in dilating the pupil, and 1 iris hook there. And you can go with the surgery more easily now and manage to get the cataract out. I would have enjoyed putting 1 more iris hook here, but I was able to proceed with the surgery with this much dilation, so I did not waste time on putting 1 more hook. The nucleus comes out nicely, and then now a stuck CTR, Suvin. So this is I call this as the suture ensured CTR. So what we are doing is, if we are not 100% sure that the CTR is going to remain, or whether you have an intact rexus or a broken PC, and there is a small risk that the CTR can dislocate into the vitreous cavity and increase the complications, you can tie just either pass it through the eyelet, or you can tie a small 10-0 suture and put in the CTR, which can easily be snipped at the end of surgery once everything goes well. So you can just see this here. We've put in a CTR which has a small loose 10-0 suture tied to the eyelet. Here you can now finish off the rest of the case more easily, and once the rexus is, once the capsular bag is clear of all cortex, you can then snip off the suture. It's always a good idea to put in a single piece hydrophobic lens, but here we are putting in a Rayner lens, I think. Not the ideal lens to use in subluxated bags, because they can open up outside the rexus and it may be challenging to get them in if the rexus is small, but here we were able to manage, and you can see now that we have the lens in the bag, so everything's gone off well. Now I'll just pull out the capsular hooks and then I'll snip the suture, or you can, if you have a loop pass through the eyelet, you can then just pull out the suture, it will just come out. So both ways are good. Now here we were able to do this. Now let me take you to another case, and we were able to save the day here. So few tips about how the vitreous can be managed and how subluxated lenses, if you're not able to get the capsular hook to work well for you. Now this was another patient which was referred to me by a colleague, and she had started off the surgery and said that the moment I started, the pupil came down and the lens was subluxated. So she panicked and she tried to do a can opener to get the nucleus out. So the rexus was all badly damaged and there was an air bubble in the AC. This was 2 days after the first attempted surgery. And I was not sure how much was the subluxation, how bad was the capsular damage to the entire capsule, whether I could have fashioned a rexus or not. And it was a challenging situation because I did not know much about how to proceed. The whole nucleus was obviously there. So she had made a scleral tunnel which I did not want to use, and I went and did a clear corneal incision, a new incision, and we stained to identify whatever remnants of the capsule were there. And so you have to be careful. You can, if it's a small pupil, you can just lift up the edge of the pupil and stain under that. Otherwise, you will not get stain beyond the size of the pupil. And then a good viscoelastic. I'm using Viscoat here because it will protect my cornea, which is already likely to be compromised, and also will give me some better size of the pupil so that I can assess. So you can see here the capsule was all torn, and there was no way I could have fashioned a rexus out of this. And I decided to use iris hooks, and 1 and 2 and 3, and try to get better visualization. As you can understand, 2-3 days after the first surgery is attempted, the cortex and the nucleus becomes very sticky and a little difficult to handle, and it's friable. And now I'm going to just increase the size of the can opener opening which she has made, so that now I'm in the peculiar situation of whether to proceed with a phaco procedure or to convert this into an extracapsular. I'm trying to rotate the nucleus and see if it rotates. It's not an ideal situation because the capsule is totally damaged, and if I do too many maneuvers, this is going to cause my PC to break. So I just decide to do a gentle attempt at phaco and see if I can divide it into 2 halves and kind of prolapse them out of the bag and then remove them. But it turns out to be a hard nucleus and also sticky at that. So you can see here that I'm now trying to drench it and debulk it a little bit, and all this while I was very worried that this is just going to extend. You can't do lateral separation because it will just cause the tears to run away. But very gently I was trying to get these small pieces out, managed to crack it into a few small pieces, no fluctuations in the chamber, bottle height was not very high, very mild maneuvers, and not coming out of the AC at any point, so that my chamber does not fluctuate, and I was able to gently then bring out most of these small pieces as I had created. So sometimes you are stuck in these situations, and now my question would be that I did manage to do a phaco here and complete the case, as you'll see here. Now I was able to remove almost all of it with a very gentle, cautious approach. I'll ask Dr. Amar how he would have handled this case differently. Would you have gone to an ECC or made a full incision and got the nucleus out, or you would have proceeded in the similar way? Thanks. Anybody would do it differently. Mohan Rajan sir, how would you do?
I will do the same thing, but I just want to comment on your first case.
First case?
The first one you showed.
Uh-huh.
Basically, I feel the problem in tackling hard cataracts and phaco is not the subluxation or the hard cataract or the posterior polar. It's a small pupil. In the beginning, if you make sure the pupil is dilated well, either with the iris hooks or whatever pupil expansion device, but do it in the beginning.
In fact, I did do it in the beginning in the first case, sir, because I started off by putting the...
No, you put the capsular hooks, no? Then
it was meant to do both things actually, the capsular hook. It would have worked to dilate the pupil as well as to, anchor the... Because I wouldn't have put a separate iris hook at that same clocker. So I wanted to just ensure that, because the capsular hook would do, dilate the pupil as well as support the nucleus. But the problem was the lens was tilted so far back in the supine position, and probably the guy who gave the peribulbar block, which I had suggested for this patient, must have given pressure for some time, and it must be because of the hypotony, the lens was probably going too far back. So it was tilted so much, which was not obviously visible on this video, but it was tilted so far back the capsular hook could not latch onto it. So then I went to just an adjoining clocker and tried to... Yes, Ajoy, you wanted to say something?
Yeah.
Better in that area?
Better than in that area.
Okay, good suggestion actually, yes.
And then instead of going,
trying to fish for it instead of that, I could have, yes.
Ajay and Gaurav, I want to tell something to all the audience. The first thing when you start, you make sure that your pupil is dilated.
Well, that's what.
Yeah, that makes the things, all the other things easy. Amar, what's your opinion, Amar? Huh? Yeah.
Good suggestion actually.
And the second point was when you are trying to get that the hook into there, a bimanual method is...
I did that, I was using a manipulator to lift up the rexus edge so that I could hold it up and then go, but it wasn't helping. So then I went, I did try.
With a microrexis forceps also, I mean...
Manipulators, micro manipulators?
Yeah.
Gaurav, one comment on your comment. So basically, I have, if you have, two situations present together, like subluxation, which request support, I would use separate hooks for the pupil and separate hooks for the capsule.
Okay, great. So here we then managed to put in a 3-piece lens, and you can see that problems don't finish. We got a small bleed from some of the haptic touching the iris somewhere. It's a very friable eye with a friable iris and everything, not in very healthy situation, but end of the day I think we were able to finish it well, and it looked like this. At the end there was this small bleed from the iris which was managed, and patient did very well later on. Thank you. I think Arup has to come up with this next. I won't, can you switch off my laptop? Yeah.
Thank you Gaurav for the nice videos. We go on to Arup Chakrabarti. I think he's the last speaker for the session. Yeah, he's the last speaker for the session, and then we can, if we have time, we can take some questions.
Last but not the least, Mohan. So good afternoon, friends. All of us do a lot of challenging situations. The most challenging situations being a very hard cataract or subluxated cataract, and posterior polar cataract and things like that. So I thought I will deal with a very interesting situation which will have a lot of teaching points. And I have nothing financial in the contents of my presentation. It doesn't move? Yeah. So some time back, I had this patient referred to me, and the referring surgeon mentioned that just the rexis was performed and a little bit of hydrodissection, and then the surgeon felt that the nucleus has dropped in the posterior segment. And then when I examined the patient on the surgical table, there is a superior incision, which there is a lot of fish mouthing, which means definitely a phaco handpiece has traveled to and fro several times through this. So phaco had been done, and there's a lot of fluffy cortical material, and that's about it. So when I examined the fellow eye had, it's a pseudophakic eye. The pupil was updrawn, ectropion UVA. So whenever you have a situation like that where the one eye is pseudophakic with a PC dent and fellow eye, the surgeon says that without any manipulations, the nucleus has dropped. So most probably you are dealing with a posterior polar cataract. So if I have a situation where I see a PC lens or an AC lens in an one eye and fellow eye has a total cataract, I'll think in terms of a posterior polar cataract. Obviously, if it was a immature cataract, the posterior polar component or element would have been visible. Then I would have taken precautions to perform surgery, taking care of and all the guidelines we have for posterior polar cataract. So let us say how the surgery went. We took up the patient under peribulbar anesthesia. A trocar cannula, 23 gauge trocar cannula system was used to make vitrectomy ports. So we do it at the beginning of the surgery before the eye becomes little hard, becomes soft. So this is for the irrigation. And then we opened up the existing paracentesis, which was a little smallish. So here my game plan is try to figure out whether there is vitreous in the anterior segment, remove the vitreous, and then tackle the residual lens matter. So a fresh paracentesis was created, and a triamcinolone acetonide, 4%, 40 milligram per ml, diluted 1:10, was injected into the anterior chamber. So this delineates the vitreous pretty well. You can see in the anterior chamber. And then left paracentesis was also enlarged because I'm going to do a manual vitrectomy through the paracentesis incision. Viscoat is injected into the anterior chamber to push the vitreous in the center so that vitrectomy becomes easier and protect the corneal endothelium. So as I did that, because the vitreous clump was centralized, and as you will see here, as I go in with my vitrectomy with the infusion inside the eye, because of the pressure gradient, the loose vitreous, which was in the anterior chamber, went behind. I'm not really bothered because, anyway, we have to go through the past manner to tackle the dislocated nucleus. So I'm using my cutter here, since I know there is no vitreous at present in the anterior chamber. So I'm using irrigation, aspiration, and cutting. So you don't really have to use a bimanual irrigation aspiration, repeatedly look for stain at the anterior segment for vitreous, and then exchange the instruments with the vitrector to find if vitreous presents. So here you just activate the aspiration, engage the cortex, bring it to the center, use a little bit of cutting, and you can remove all the cortex that is present using the vitrector itself. You have to be a little guarded and tentative when you go under the anterior capsule because you don't want to be damaging the anterior capsule. We require, the posterior capsule is gone, so you require the anterior capsular support to fixate the lens. So one has to be very, very careful here. So the last bit of cortex is removed, and I could make out that the patient had an irregular rexis, but it was fairly intact in the visible areas. And only question is what is there in the subincisional area, the 12 o'clock. There is amount of iris fraying, so obviously a lot of phaco had been done by the initial surgeon. So I used a Kuglan hook to make sure that I have good visibility, and yes, the rexis margin was intact, and it was fairly small. It was less than 6 millimeters in size, which means I have enough space to fix the lens in the capsular bag. I can achieve a buttonholing of the optic. So I'm using predominantly viscoat. It is a good idea to use viscoat in a patient situation because postoperative ocular hypertension, which is associated with HPMC, is not seen with viscoat. So once the peripheral anterior chamber, posterior chamber has been formed, we are ready for the lens implantation. Eye is very soft. So sensor lens requires an incision of 2.8 millimeters. But then but since the eye is soft, there's a lot of manipulations, the wound gets distorted, a globe tends to collapse and the OVD comes out. So it is always a good idea to have an incision enlarged to about 3 to 3.2 millimeters in size. And then the entire lens, if you see here, is delivered in the anterior segment, in front of the iris, because I was not really sure whether the leading haptic will land up in the ciliary sulcus. So once that is done, the haptic is compressed. You can use the Sinskey hook, you can use the Kuglan hook or any push-pull instrument, and they're gently tucked under the iris. So you can rest assured that the haptics are going to be placed in front of the anterior capsule. And once that is done, so this is what normally seen in the sensor lens. It is in a lot of air bubbles that doesn't really impair the visibility. In first postoperative day, it comes down. So I have pushed the lens, the optic, into the capsular bag. So it is quite a desirable situation. Though the lens is lying in the sulcus, so still the lens is well locked, in place, and is not going to get decentered in the postoperative period. So finally, I removed as much of the vitreous from the anterior segment as possible. All these incisions, whenever you have a compromised capsular bag, PC rent has occurred, zonular dialysis, vitrectomy has been done, it is always a safe idea to put a suture instead of doing very aggressive stromal hydration. And through the past manner using the fragmentome, the lens matter was removed and the patient had done pretty well in the postoperative period. So I just want to tell you one message, that whenever you have a compromised bag, please do not use a single piece hydrophobic acrylic lens in the ciliary sulcus. Instead of that, you should use a lens which has got all these features. Ideally, it should be 13.5 millimeter length and 6.5 millimeter optic. We don't have such a foldable lens in the country at present, but hence we use a sensor lens and it has been doing pretty well. This has an opti-edge design, so we really don't have to worry about the square edge. Now, when you keep a lens in the sulcus, you need to modify the intraocular lens power, because as the lens migrates anteriorly, it becomes more powerful and you have to reduce the IL power. You can get the conversion factors in the Warren Hill website. The rule of the thumb is, if you're keeping a lens in the sulcus, same lens if you're keeping in the sulcus, you have to reduce the power by 5%. So friends, this patient had done pretty well, though the complication could have been avoided by the initial surgeon, but even though the complication happened, due to proper strategy and proper management, the patient had done extremely well. Thank you so much.
I think you have, I'm sorry, Arup, you have covered the points very well. If you notice, he has given beautiful two messages. When you have a posterior polar cataract, when a patient comes with a posterior polar cataract, total cataract, white mature cataract, and you do not know whether it's a posterior polar cataract, what do you do? Always look at the fellow eye. If you look at the fellow eye, the patient's got an ACIOL, an iris claw, a lens in the sulcus, then that will give you an indication that this patient has got a posterior polar cataract. So that one message he gave. Second message is, whenever you have a compromised capsular bag, either a zonular this thing, which we were mentioning earlier also when Chitra was talking, always use a multi-piece lens. Either go for an Acrysoft MA60 or a sensor acrylic, whatever you are comfortable. Put the lens in the sulcus and and capture the optic in the capsular excess margin. That will ensure long-term stability and centration, and also prevent this UGH syndrome, which is again another problem which you can face.
See, in connection with Suven's talk, Mohan, I just want to make a point. Suven, of course, had a very good discussion. See, all my micro instruments, every week they're examined under the microscope, so that you don't have any sudden surprises on the surgical table, number one. My nurses do it, I have trained them to do it. And number two, all my sharp instruments, stainless steel instruments, I replace them every year. It really doesn't cost you that much, because it's not titanium, it is stainless steel and you're replacing them every year. So that way you can maintain a really good quality of surgery.
Any questions from the audience on this particular topic, Arups? Yeah.
Sir, you have started a case and you have done hydrodissection and the lens is hard and you find that probably there is a posterior capsule rupture and the nucleus is tilted. How would you like to proceed further?
Sir, I think it's a great question. So you have a hard cataract, and in patients with hard cataracts, really advanced age, so the posterior capsule is thinner. So hydrodissection has to be done very, very carefully. The incidence of pupillary snap in these cases is higher because of the fragility of the posterior capsule. Your X-ray should not be too small. should never be less than 5 millimeters, say about 5 to 5.5 millimeters. Otherwise, the rhexis block, intraoperative rhexis block can occur, and that can give rise to the pupillary snap. Okay, this is the prophylactic aspects. Now, when you have a situation like that, a snap has occurred, it is very important for you to detect it immediately. Otherwise, if you continue with phacoemulsification, you're 100% going to drop the nucleus into the vitreous cavity. Now, how the nucleus behaves depends upon a lot of factors. The nature of the vitreous. If it is a liquefied vitreous and you haven't realized it, and the PC rent is large, and you have gone with the positive pressure in the anterior chamber, nucleus are going to go down. So I would say that whenever you have a hard cataract, pupillary snap has been diagnosed, convert. I would do a SICS technique. I'd close the clear corneal incision and make a scleral tunnel incision and make generous, about 6.5 to 7 millimeter incision for hard cataract because there's a PC rent, and convert to an SICS technique.
Or you can do, if the nucleus is not gone in, it is still there, you can do what is called anterior assisted levitation. Only thing is, you have to make sure that these patients are followed up very carefully.
Yeah, what Mohan is telling, I think, about the posterior assisted levitation, that works well. Mohan's hands and explains. He's a VR surgeon, but for an anterior segment surgeon, I think if you go to the past canna and try to levitate it with an instrument, even visco levitation, that can be done. That can save your scenario. But I think the posterior segment surgeons, if there are any here, I mean, other than Suven and Mohan, will not be very receptive to this idea.
We have some time. And Kumar.
No, Suven, you want to say something?
Yeah, levitation is one thing and supporting is another. So your immediate plan is you've had a blowout, so probably you want to assess the situation. It's a good idea to just put a 24 gauge needle through the pars plana and support it behind, and then you see what you want to do. Then you want to convert to a SICS, you have time, so you have it holding, or you could ask your assistant to hold that needle over there and just support that nucleus while you are doing your SICS incision and stuff like that, because the SICS incision is also going to be manipulations and you might drop. You don't want to get into a situation which is worse than where you started. So you don't have to really go in for levitation and continuing with phaco. We are not, that is not our target. The idea is to buy some time. So putting in a pars plana 24 gauge needle, which is long enough, and if you can pith the nucleus, fine. Even if you can't pith the nucleus, but remember it's blind, so you should know how much of the length of the needle is going inside. So that's something.
Yeah. Thanks.
I'm just going to have 3 minutes. I'm just going to show one interesting case. This is a subluxation here. Vitreous is coming out in this area. Okay, I've marked the amount of subluxation, and I'm operating this case now. So I'll tell you what all I did. There is a traumatic cataract, so you see a large defect in the iris. So what to do here? So I'm just trying to show some steps. We make a side port, put in triamcinolone, and then do vit, which is there. So I'm doing vitrectomy, and you can see it's a 2-port. So removing all the vitreous that is present here. And you can see the subluxation here, but the rest of it is actually extending till there. So now doing the rhexis, so you can see when the rhexis is done with the forceps directly, see the way the anterior capsule behaves. There is no counter traction. So you can see the subluxation here. There's no counter traction holding on. And so this is how your eye will actually behave. Now this is the trick I was talking about when I said something in the morning as to I want to put the endocapsular ring before phacoemulsification. So this is the trick you follow. Just put in viscoelastic. So you can see I'm putting in viscoelastic just below the rhexis. So I put in, and it goes till the fornix. So I'm going all around, mind you, everywhere, okay? And then put in your endocapsular ring. This will not entrap your cortex, and it will make your life very, 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 very easy. So now the way of putting the endocapsular ring, many methods of doing it, you can do it with the injector. But if you're doing it like a gliding method, I prefer to use only a side port. Never put an endocapsular ring through the main incision. I always put it through the side port. One more lesson to learn here is, I have put the endocapsular ring from this side. Actually, I should have put it from this side because the 2 eyelets will come here. Here, what's going to happen, the subluxation is here, and I'm putting this here. So you will see that the endocapsular ring with the eyelet comes in the area of subluxation. Can you see that? Now, this is a bimanual method of putting it very, very easy. It just glides into position, and that's it. So you can see the subluxation now from here till here. Now, if this further goes like this, you don't have your support in the subluxated area. Then you may have to rotate. So what I'm doing here, I'm rotating the eyelet. So I'm actually rotating the endocapsular ring anti-clockwise to give me full support in the area of subluxation. So if I had put the endocapsular ring from this side, the two eyelets would have come here and I would have got excellent support here. So that's mistake number 2. Always remember to put the endocapsular ring from a side port opposite to the area from the subluxation, then your eyelets will come in the same area. Do I need capsular hook? The answer is no, because now I already have my endocapsular ring, but I still thought I'll give additional support to this, but then I decided no. I gave little support and then do phacoemulsification. And when I'm doing IA, you'll see the ease with what the phaco is already completed. The ease with IA just comes out. As I mentioned, because the cortex is not entrapped, it easily comes off. So you can just see that it's coming off very, very easily. Once that is done, go ahead and put the lens in the same area of the subluxation and your whole case is done. So, and last step here I want to show you, I put the lens. Now the lens is again placed in the area of subluxation. So you can see the haptic is in the same direction. So I have my endocapsular ring, I have my haptics here, and now I have to correct this. Right, so these are micro grasping forceps. So just pull it, okay? And now I'm doing a 4th row pupilloplasty. Excellent technique devised by Dr. Amar, and very useful in this case, made my life very easy. I'd never done a pupil repair before. This is the first time I was doing it. So I passed it through. This is a 9-0 proline suture, goes through, and you have to come out here, just hold it. And once that is done, you can go ahead and do 1 throw. And then you need these micro scissors, okay? So you just cut that knot off and that is done. Do once more, and at the end of it, so you'll see that I'll do 1 more. So these you need 2 instruments, micro grasping forceps and micro scissors. They are not very expensive. Then you do a second attempt of the same 4th row pupilloplasty. This is a method devised by Dr. Amar. All of you know this. Anyway, it's done. So this way, at the end of the procedure, you do it once more, so you have a nice round pupil and everything is done. So that's what I wanted to bring to your notice. You can end the video. Thank you all for your attention, and thank you for coming for the course. You can shut the video. Thank you all. Any questions anybody has, and we can answer it for a minute. Otherwise, we are closing the course. Dr. Lahane for the next course is already here. Thank you all very much.